Well, good afternoon, everyone, or good morning, wherever you're joining us from. I hope you're having a sunshiny day today, wherever you are. I'm Glenn Landers with the Georgia Health Policy Center, and I am the co-principal investigator of Aligning Systems for Health. We've been supporting 17 grantees over the past year with our partners at the Robert Wood Johnson Foundation, and they've been helping us to learn about aligning sectors. And today we'll hear from the first three. The three that we'll be hearing from are what we call our rapid cycle research grantees. And they are the ones that are doing their work in just under a year. These are the first three that have finished their work. And the next three we'll hear from probably in February. So be looking for an announcement from us for that next round of rapid cycle research results. Throughout the program, please type your questions into the chat and I'll get to them during the question time at the end of our presentations. We have a number of speakers with us today. Georgia Health Policy Center's CEO, Karen Minyard, will kick us off with some context for the research results you'll hear. We'll then hear from our three researchers, Murray McLean, Mark Redding, and Allison Solomon. Hilary Heischman, our senior project officer with the Robert Wood Johnson Foundation, will provide reflections on the research and place it within the larger body of work being supported by the foundation. So again, we'll have time for questions at the end, so please do put your questions in the chat. Karen, I'll turn it over to you. Just take yourself off mute, Karen.
Thank you, Glenn, and welcome everybody. I'm glad to see all of you here today and excited to be able to share this information with you. I wanted to say just a few words about reminding everybody about the work of the Aligning Systems for Health project. So we have a part of the project that is related to synthesizing the existing research and trying to make actionable the results and make it available to those who might benefit from it. Another component that we're talking about today is supporting original research. And as Glenn said, we have both large and small awards that are part of this. You also, I think, are part of what is the third listed here, which is building relationships. This whole idea of having a learning system where we're all getting smarter together is a part of this work. And that includes what we do together and other opportunities that we have to learn together that you'll hear about, and also from our technical advisory committee. You might remember seeing this picture. It's one that we started with at the beginning of our work 18 months ago, where we talked about the alignment of healthcare, public health, and social services, and how that plays out with the different components of purpose, data, financing, and governance, and resulting in the health and well-being in communities. Over the last 18 months, we've been working hard in the literature, in our conversations with you, and maybe even a little bit from some of the beginnings of the research that we're hearing about today, to try to think about how might this particular figure better depict the experience that we have nationally as we think about cross-sector alignment. And this is the next version of this framework for aligning sectors that has emerged. And I wanted to say a little bit about why it's different. One thing is that what we heard from you and from the literature and from the research is that these core components of shared purpose, data, governance, and financing are not stagnant, that they are dynamic and interactive, and there's not necessarily one that comes before the other. So a part of this new visualization is to think about these core components in this way. Another part of this is that as we were doing this work, some what we call adaptive factors emerged as very important. And while they have been a part of previous versions of this work, maybe the emphasis wasn't as strong as we feel like it should be now based on the work that we've done. So these issues of community voices, equity, power dynamics, and trust have emerged as very important, and also interacting within and among these core components. Another part of the work is that there was there were a lot of questions and about, so what happens between this aligning work and the outcomes? The outcomes that we've depicted here as shared progress toward communities' goals and needs, health equity and racial equity. And we realized that there were some more proximal outcomes that were important for us to think about and pay attention to. So those changes in mindsets, practice, and policy were some of the key proximal outcomes that emerged and made us be able to think a little bit about what happens before you actually get to the long-term outcome of health equity and the others. Our work has been, over the last 18 months, a part of this building a learning system. And you're a part of this because you're bringing your own knowledge, you're bringing the literature that you've been a part of or have read. And so far, there has been a diffuse understanding of what works for whom under what circumstances. But the research and the experience that we have is moving us toward a more consolidated understanding. And I didn't know what song Glenn was going to pick for today. I've just been saying I wanted music. But when it said, I can see clearly now, the first thing I thought is that the framework has become more clear. It's become clearer to us. And we're moving from a very diffuse understanding of this work to more and more consolidated understanding, and just spending time together to build that. And those people that you're going to hear from today who have done research are making a special contribution to bringing their research into our knowledge and us being able to all hear it and think about it at the same time, and then have that dissemination process where we all are able to share some of the same things. So building this consolidated understanding has been a big part of this work, and it's a big part of what we're trying to do today.
Thanks, Karen. So to kick it off, we have Mireille McLean from Public Health Solutions. And Mireille's work really focused on the core components. So as you're listening to her results, think about purpose, financing, data, governance. And she was also thinking about the capacity that organizations need to do this work. And I'll steal a punchline from Mireille right away and say, she was one of the first grantees that was directly impacted by the pandemic. So I think it's going to be very interesting to hear how they repositioned their research, and I think came up with even possibly more interesting findings. So Mireille, I'm going to stop sharing my screen and you can take over with your slides. And you have about 10 minutes. I'll give you a 2-minute warning.
Okay, so I'm looking at the shared screen and it doesn't give me yet an option to, okay, here you go. Share. All right. Can you let me know with a nod, Glenn, as I see you, if you are seeing
Yep.
my screen? It's not coming up in.
Yeah, just
There
click
you
it.
go.
There you go.
Wonderful. Okay. Thank you very much, Dr. Landers, Dr. Miniard, for inviting me to present the results today. I'm really excited to do that. I'm Mary McLean. I'm Deputy Director of Neighborhood Health at Public Health Solutions. We're a large multi-service organization in New York City. And at PHS, we wanted to test the use of the cross-sector alignment theory of change to see how it could enhance alignment between community-based organizations and hospitals, so that the quality of referrals made by clinics in hospitals to social services would be improved and ultimately more people would receive services. We did that in the context of demonstration projects where CBO staff were embedded in 3 hospitals in clinical settings in the municipal health systems in New York City, health and hospitals. And these CBO staff were meeting patients to address their social determinants of health needs and connect them to services. To study this, we wanted to use a mixed method approach with qualitative interviews and quantitative measures across the referral cascade. So the project started around a year ago in November 2019, and within a few months of implementation, we were struck by the COVID-19 pandemic. So you will remember that time. You can imagine easily how immensely disruptive the pandemic was to the health systems. Very quickly, they had to focus exclusively on treating COVID-19 patients, and they fought not to be overwhelmed by the disease. That means that all embedded programs like ours were interrupted, and the CBO struggled to try and address the needs of the population while keeping their staff and clients safe and transitioning to work from home. So for vulnerable New Yorkers who typically go to safety nets hospitals, it meant that this access was virtually interrupted. So what happened to our project? We adapted and we pivoted. So before the pandemic, we had quite a simple workflow. The provider in the clinic identified patients with needs, the CBO staff met the patients with needs, and the patient received the services if they agreed to enroll. During the pandemic, 2 important elements. First, the clinical provider was completely removed from that workflow, because what we did is that the Health and Hospitals Office of Population Health generated list of discharged patients and shared those lists with the CBOs. And the CBOs called the patients to enroll them. So what we did is that we removed the clinician from this process. We also greatly simplified the workflow because there was no longer any eligibility criteria, and the CBO staff conducted the outreach. There was a joint leadership in place to manage that really jointly developed all the tools and all the workflows to make that work. But before I go into the comparison, I do want to stress that before the pandemic, the 3 sites that we're focusing on actually had quite significant nuances on how they implemented the project. Site A had a very collaborative approach. The staff participated in huddles, and that's how the referrals were decided. They were focused on just 1 clinic, and they had very simple criteria. In Site B, the CBO staff were also embedded in just 1 clinic. It was the emergency room. They were also working very closely with the social workers there. But because it was the emergency room, it received, the ER received a lot of different projects, initiatives, resources, and so the algorithm was a lot more complex to decide which patients could be enrolled or not. Site C decided to make the project available to as many patients as possible. So they didn't embed the CBO staff into just 1 clinic. What they did is that they developed a checklist that the clinical staff was going to use to identify who was eligible and then who was interested. Then they would let the CBO staff know that there was a patient who was interested so that the staff could meet that patient at website. So to develop that checklist, they came with a number of criteria and it was a lot more complex. So you will see Why this is important. So these are the findings from the quantitative measures of referrals made, those that were eligible and those that were enrolled before the pandemic. And what you can see here, I won't go through all the details of that slide, but what you see here is that site A is a high performer. They receive a high volume of referrals. Most of the referrals they receive are actually eligible due to the joint decision-making process. And a large number of those patients actually elected to enroll in the program and receive services. Whereas site B and C performed about the same and not as well in terms of referrals and referrals eligibility, and they had also much lower enrollment rates. What happened during the COVID-19 crisis? So we focused on the months of April and May, which was the peak of the crisis in New York City. And you see on that slide, so all the referrals were eligible because we got rid of any eligibility criteria. The numbers of referrals were different based on the volume of patients that were seen by those hospital sites during that time. And you see varying degree of enrollment rates. So there are two things that we learn here. The first thing is that overall, we continue to serve patients and we actually increase the number of monthly patients that were enrolled. The numbers are not large, but I want to emphasize that it was seen as very successful by the hospitals, very successful by the CBO, because nowhere else were there actually a way to connect hospital patients to services as effectively as we did through that project. But the second thing that needs to be stressed here is that hospital Cs that use the checklist that has a much broader scope of work with less integration, less collaboration, less coordinations between the team had a much smaller enrollment rate. And we suspect that there was really the role of the trusts that was established between those team members when they were working together before the crisis really continued and translated into higher enrollment rates after the crisis struck and when we started working with that different workflow. So what we want to do now is to map those findings and map the results of our qualitative interviews to the core components of the theory of change. So we interviewed 18 people who were patients, CBO staff, and clinical staff. And we analyzed their results keeping in mind the theory of change core components. So we first learned, and this is not reflected in that table, that for patients, the referral process was invisible. They were glad to be referred, but it didn't really matter how it was done. But from the staff perspectives, both clinical and CBO, we learned that when a project really had a clear scope of work with collaborations and joint decision-making process at the core of implementation, everything else seems to flow from there. So that clarity meant that there was no hesitations about who should get what. And in terms of roles, there was no hesitation or even tension about who does what. So in terms of governance, the sectors that were able to get together to decide on a referral together before COVID-19, and that was translated after COVID-19, that really seemed to have a large impact on the success of the project. And one question mark that I have here, and I want to highlight for this group, is the role of the clinician in introducing the services. We saw that we were successful when we removed the clinicians, but this was a time of crisis when we really could not continue to go out for the clinical providers and engage into that program. But we really think that based on the results across the 3 sites, the fact that there was some element of collaboration that existed was something that the teams, the CBO teams, were able to lean on when they were conducting their outreach. And so there is a question and further research needed possibly about how to position the role of clinical providers if we really want to build well-aligned systems. So our lesson—
about 1 minute, Muriel.
Thank you. The lessons learned from that was that a common purpose is very important, but it should be translated into a clear, well-delineated scope of work that highlights the settings, that highlights who does what. And variations in role definitions appear to be connected with variations in program performance. In addition, we learned from the COVID-19 crisis that well-aligned cross-sectoral projects that have been together concurrently appear to be resilient to crisis, and that the trust between the partners, the clinical partners, public health partners, social service providers, actually translate into trust with patients and clients for those programs, and that supports the goal of the entire system. So I want to end by thanking my co-PI, Dr. Tobin, at the Clinical Director of Network in New York City, the PHS teams that work with me on this. I want to thank the CBOs, the clinical teams, and the patients who agreed to be interviewed, and the Georgia Health Policy Center for their support and guidance with this work. And that's it. Thank you very much. And I'll be there at the end for the Q&A.
Thank you so much, Muriel. So next we have Mark Redding. And Mark and his team were focusing on, again, the adaptive factors, the core components in the theory of change. And he had high involvement of community stakeholders in the work. So as you listen to Mark's results, you may want to think about how the involvement of those stakeholders actually impacted the work. So take it away, Mark.
Thank you, Glenn. Am I coming in okay?
Perfectly.
Okay, good. Well, thank you again for this opportunity. Thank you, Georgia Health Policy Center and Robert Wood Johnson. What a great thing to be part of, and what exciting work we've got to hear so far. Our team focused on, give me just 1 second. So our team focused on the question, does the nationally certified Pathways Community Hub model align with public health, healthcare, and social services in a manner that's consistent with the Robert Wood Johnson theory of change and the core areas of alignment? The Pathways Community Hub model is a nationally certified, evidence-based model of care coordination that works to engage local communities and community members in advancing a whole person approach to identifying medical, social, and behavioral health risks, then assuring that they are addressed. The Hub model is founded on an authentic engagement of communities and community members as a central component for both health and social service intervention. This model utilizes a published framework of modifiable risk factors that span health, social, and behavioral health. Instead of focusing on just medical, just social, just behavioral health, or one or two risk factors within those domains, this approach recognizes that a full span of modifiable risks across healthcare, public health, and social services is critical. A whole person approach is needed. Interestingly, we may not be able to achieve health or wellness just focusing on a single risk factor or a single domain of risk, such as medical care, connection to housing, behavioral health. Any one of those isolated areas may leave out key factors. Risks across domains are increasingly being substantiated as interlocking and interconnected in their impacts on outcomes. Our first research aim was to try to define just what these individually modifiable risk factors are, especially those that are relevant to care coordination. We published this in the Journal of Preventive Medicine in early 2020, and we've begun to make additional efforts to try to identify the weights of impact of these particular risks on specific outcomes, as well as the potential to learn more about signature combinations of risk or groupings of risk factors that substantially amplify or increase the impact on outcomes. If learning more about those may allow us to more effectively target or reach out to people who are more at extreme risk and more accurately focus those resources. One of the most interesting findings in the literature review process for this research was demonstrating that combinations of risk factors and a whole person approach may not only be important to pregnancy, where we have focused our research interests, but also to employment, school success, chronic disease control, and others. So the way the hub model works is that a community health worker who most commonly comes from an agency actually within or part of the community served reaches out to an individual who's been determined to be at risk and conducts a comprehensive whole person risk assessment. Specific risks that are identified then are assigned a pathway, and the job of that pathway is to document whether or not the risk has been successfully mitigated. Instead of counting how many clients or how many process items are completed, it's how many specific risk factors have been addressed. So in our Georgia Health Policy Center alignment grant, we were called to investigate the core areas of alignment, including purpose, data, financing, and governance, and understand them in relation to the Pathways Community Hub model. So our objective number one was, do the national standards of the Pathways Community Hub model align with the core areas of alignment? And we reviewed these certification standards and compared them and ranked them through an objective process with each of the core areas of alignment. And our research team identified that the Pathways Community Hub Institute and the Pathways Community Hub standards could be improved, especially in the areas of governance, which has already been presented to the Pathways Community Hub Institute for possible changes. Overall, our analysis demonstrated significant alignment of the Pathways Community Hub Institute standards and their impacts on alignment. Our objectives 2 and 3 involve case studies of hub directors and the broader community network within each of the local hubs. We have completed these assessments for 3 hubs and are actually working towards full completion for 5 hubs. We've conducted about 18 interviews thus far. One of the things observed in this questionnaire process was that hubs that are not certified yet may not have the same strengths in financial accountability and focus on financing that hubs have that are certified. And so that we thought that was fascinating. And then again, within governance of hubs, we identified that they could benefit from greater engagement, especially with community leadership such as county commissioners and others. Overall, our sample of hubs have demonstrated significant alignment with the core areas of alignment. Objective 4 was more of an exploration, and we did not feel that we could produce publishable research in this area. It was an exciting area to explore. The hub model utilizes published whole person framework of risks as their nationally standardized pathways to determine if those risks are addressed. This is an example of the data that we obtained from one of our enrolled hubs. And this data is produced by all hubs nationally on a quarterly basis. Or if it's not, it soon will be, but most of them. And what's fascinating about this, as we begin to examine the relationship between the core areas of alignment and this data, is, for example, this hub is showing that they were not able to be successful in mitigating 1,645 risks for this period of 1 year. And those risks included things like housing, adult education, employment, connection to medical care, food, clothing, and others. Further research can identify some of the reasons why they were not successful, and in a way that I don't think will surprise anyone, housing, for example, was one of the most significant problem areas or challenge areas. What is also exciting
We lost your sound, Mark. I wonder if your microphone was unplugged. You should be good now, Mark. Just unmute yourself.
Can you hear me now?
There you go.
Okay, great. Yeah, I was on my phone and it dropped the call, so not sure what happened, but so in closing, this particular example hub was able to effectively address 13,777 risk factors. Again, spanning housing, food, clothing, connection to medical care, and others. And the percentages of that success are able to be visualized. So it is definitely our goal to expand this research and the related items that we have learned from this research project. And obviously in a very appropriate way, the research so far is generating more questions than answers. But I think with the guidance that we've achieved here and the results that we've achieved here, we've made substantial steps in progress. I'm sending it back to Glenn and Allison, and thank you again for this opportunity.
Thank you so much, Mark. So our final presentation will be made by Allison Solomon. Allison, if you want to go ahead and start sharing your slides. The interesting thing about the work that Allison did was that it was the first of our grants to focus a bit on equity. So be listening for that as Allison is presenting her findings.
Great. Thanks so much, Glenn, and hi, everybody. Thanks for having me here today. My name is Allison Solomon, and I'm a consultant with JSI out of the California office. But I do want to begin by acknowledging that I'm actually joining you today from the land of the Shakori and the Eno, also known as Hillsborough, North Carolina. And the Shakori and the Eno are the caretakers of this land that I'm on, and I'm grateful for the privilege to live, work, and grow here. And I'm also excited to speak to you today about the research that my team did. And as you can see here, we were working directly with the now outdated Aligning Systems for Health Theory of Change model that was developed by Georgia Health Policy Center and RWJF. And I was really excited to see that new updated model today that Karen shared, because some of the findings that I'll be talking to you about today are actually reflected in that new and updated model. So really exciting to see how this process is iterative, and that's being reflected even through the research. So as with the other two presentations that we've already heard, I want to draw your attention to those 4 multicolored boxes at the center of this model, because that was the focus area for our research team as well. And of course, the model theorizes that those 4 elements, purpose, data, finance, and governance, are critical core components that help achieve the goals and alignment of multi-sector health collaboratives. So even though not all multi-sector health collaboratives are necessarily using this exact model, most do identify a similar set of core components. And our research team wanted to look at how initiatives are sequencing attention to these components and developing them. And we were also interested to learn whether and how equity has been addressed during the development of each of the core components. So to explore those questions, we connected with 3 initiatives engaged in the work across the country: the Build Health Challenge, Way to Wellville, and the California Accountable for Communities for Health Initiative, or CACHI. And our approach was to first scan the practice literature and published research in order to ground our work and help develop interview guides that we then used with key informants. And we held a series of key informant interviews with each of the groups, resulting in a total of 9 interviews. and we interviewed an initiative leader, so someone who was in leadership at Build, Way to Wellville, and Catchy, as well as site leadership, so people who were doing the work on the ground. And we reviewed planning and monitoring documents such as proposals and guidance and evaluation materials that were provided to those individual sites by their associated initiative. And the findings from our literature scan, the interviews, and the document review were synthesized, and I'll be sharing some of those results with you here today. So our first key finding was that initiatives really fall along a spectrum in terms of flexibility. They fall along from flexible to pretty prescriptive, with some initiatives taking a very hands-off approach to the development of the core components of their sites, while others are providing a lot of structure and really push sites to check the appropriate boxes at the appointed time. And in general, we found that initiatives that were more focused on outcomes tend to be more prescriptive, whereas those that are more focused on capacity building tend to be a bit more flexible. And really, this is a place of tension for the initiatives because they have to figure out how to strike that balance in order to enable site development that reflects and is responsive to the local context within those communities, but the initiatives need to ensure that best practices are being used and that there's a consistent model being developed ideally. So a second key finding is that of the 4 core components, sites are generally starting with, and really they should start with, developing purpose and governance. And these were viewed consistently as early work because they come first sequentially, but it's important to note that developing those 2 components is really difficult and it can be extremely time consuming for sites. But there are these long-term benefits associated with getting them right because once they're firmly in place, it lays a strong foundation for the overall success of a site. So there's a temptation among some sites to jump straight into data, but success in data in particular seems to be really dependent on pre-existing capacity. And there were very few sites that we talked to that have actually been successful in fully fleshing out the data core component. In general, governance seems to be closely tied to success, and strong governance can be a catalyst for effectively developing the other core components, including data and financing. Our third finding relates to the importance of leadership at the site level. We found that successful site leaders are community organizers at heart, but that they also have an entrepreneurial spirit. And so leadership at the site level has many implications on site development because leadership style and comfort with leadership, particularly with regard to community engagement, can have a lot of influences on how governance takes shape. And again, there's a tension that can arise because leaders need to have authority while also being in service to and perhaps members of the community that they're in. So individuals have to be able to reconcile the initiative design, which gets back to the prescriptive versus flexible approach, but they also have to acknowledge and work along with funder wishes and the local context. So of course, it's a tough job, and there are a lot of implications on how a site develops just based on that leader. Our fourth key finding is that trust and relationships are really essential to the work, and that the development of trust and relationships requires explicit attention. And as we covered earlier, the successful development of governance and purpose is key to the long-term success of sites, and trust and relationships are central to both of those core components. So building trust and relationships explains in part why the development of purpose and governance can be so time-consuming. Obviously, we don't tend to build strong relationships overnight, and particularly not in communities that are experiencing long-standing power imbalances and historical oppression. So trust and relationships are central to the development of governance because sites have to figure out community participation, and they're central to the development of purpose because there's a need to understand the local context, and purpose should be informed by the audience and the value proposition of the site. And then our fifth finding relates to equity, which we generally found was everywhere in theory, but largely absent in practice. So there's a notion that equity is a cross-cutting theme that runs through everything, but in reality, that can mean that it doesn't specifically appear anywhere. And only one site that we connected with actually had evidenced their operationalization of equity. Even so, sites generally agreed that equity does need to be specifically named and operationalized within purpose and data and finance and governance. And we posit that in order to achieve that operationalization across the 4 core components, sites need to engage in early, regular, and genuine community partnership, which is, of course, not quick or easy. So going back to the earlier mention of power imbalances, genuine equity work is going to require the explicit examination of power, which is a difficult process that can only happen if there's a level of trust that's been established. So here's a diagram that integrates some of the key findings. Of course, if I had Karen's new updated alignment figure, perhaps I would have shown that instead. But this is what we kind of came up with. So we found, to briefly recap, that initiatives fall along a spectrum from flexible to prescriptive, that sites are generally starting with developing purpose and governance, that leadership at the site level is critical, trust and relationships need to be developed, and equity needs to be intentionally operationalized throughout the process. So initiative prescriptiveness can impact site leadership, which in turn has major implications on the development of governance and purpose. And the development of these two core components hinges on trust and relationship building, which, if successful, can then lead to the successful development of data and financing and program implementation. So where do we go from here? Well, we need to investigate effective equity practices, including learning more about the guidance that's coming from initiatives and what's being developed and used at sites. Second, we think it's really important to clarify what makes for successful local leadership, and then begin to develop strategies to build out that capacity. Additionally, we think there's a need for more case studies, allegories, and metaphors that can help illustrate that this work is iterative and constructive. And again, going back to the gears and the updated model, that shows that iteration kind of inherent to the work. So that's great. And finally, we recognize that additional strategies and technical assistance are needed to support sites transition from their initial funding sources and towards more sustainable long-term models. So in closing, I just want to extend my thanks to the other members of my project team at JSI, Mia Bladen and Jeremy Cantor, as well as to the 3 initiatives we worked with, and of course to the team of folks at Georgia Health Policy Center who were so helpful in getting this work off the ground. So thank you very much.
Thank you, Allison. I will switch back to our slides here. And I did want to emphasize that, as Allison pointed out, the framework has iterated from the theory of change, and it is the results of projects like these that we took into account in addition to the literature that led us to that framework. So our goal is always to make the framework more evidence informed, and these 3 projects are some of the results that have helped us accomplish that. So please do get your questions ready. I already have a few that have come in, and Hillary Heischman now with the Robert Wood Johnson Foundation is going to share some reflections on this research and also put it into context of the larger work that the foundation is doing. Take it away, Hillary.
Thanks. And can you hear me?
Can hear you, yes.
Okay, great. The research that you've been hearing about today, it really is, just as Glenn just said, it's informing the evolution of this framework. It's informing Robert Wood Johnson Foundation's funding strategy that's helping strengthen connections and alignment among public health, healthcare, and social services to help those systems together do a better job of meeting the goals and needs of the people they serve. So it's the strategy and the framework you saw were developed actually certainly recently using this research and other people's programs, but actually using years of evaluations and insights from many people, including many of you on this webinar as I scroll through the faces, using years of your insights and evaluations of your programs went into the first iteration of this, and have also informed the second one about insights about complex systems change and about ways that different kinds of organizations have improved and sustained their work together, because we all know how tricky that is. The research that Aligning Systems for Health supports and their translation of it, it's helping us at RWJF and people we're funding across the country to assess and to refine our strategies. We're going to be able to share more practical evidence-based information and guidance as a result of this research. And increasingly, we hope it can help different efforts and programs coordinate more with each other. We hope the framework that Karen shared can become a useful guide for the field. And we look forward to continuing to use it. So go ahead to the next slide, please. My colleagues and I at RWJF, we've had a variety of questions about this strategy since we started developing it. We've been wondering, does aligning public health and healthcare and social service systems towards the goals and needs of the people they serve, does it actually help measurably improve health and well-being and health equity in the community or across the whole state, if those systems are aligning across a state, and in what circumstances? We've been wondering, what are the most important features for each of those 4 core components that were inside the gears? What are the most important features of those of a shared purpose and governance and data and financing? We've been wondering, what are the patterns of how the technical and the more adaptive aspects of how they work together to support the different systems to work together and to align? Does developing those 4 core components, the parts in the gears, in a certain order, make the connections among the sectors more sustainable? Importantly, what does it take to dismantle structural racism and systems that perpetuate white supremacy through the process of aligning systems? We also wonder about in these relationships between public health and healthcare and social service organizations or agencies. We know that there's the power imbalances between those organizations that affect if and how they coordinate and are able to work together and align. So does the power need to be balanced for alignment to work? And what does that look like practically? We've also been wondering, what does it take for systems to connect and align in ways that are human and community centered, especially so that aligned systems really do meet the goals and needs of the populations they serve that are most affected by inequity. And of course, we wonder what we're missing. So you heard reflected in all those questions that because I'm speaking after the researchers, you can tell we've been getting answers to some of the things that we've been really wondering about this cross-sector systems alignment strategy. So I've been especially grateful for the insights that they've been sharing. Next slide. So to reflect a little bit on our 3 researchers directly, many of us have thought for some time that sectors working together and operating greater alignment can contribute to greater resilience in times of crisis like COVID-19. So we've really appreciated the research that Mary A. McLean described that sort of filled out our understanding of the role alignment can play in resilience. That they're helping us understand what it takes to develop what it really takes to develop a shared purpose, not just to say it as a thing that we think matters, but like what is in that, to develop a shared purpose across organizations that actually helps them work together better. Their work also is helping us understand the role that trust plays, and you can see trust is one of the elements that's been built into this new version of the framework, and how it really does seem to wind through all the other components. From the work Mark Redding described, in which we're learning from the Pathways Community Hub communities and model, it's been really valuable to learn about the concordance between their certification standards and prerequisites and these components of alignment. Being able to compare the 2 has been really valuable. It reinforces how important it is to learn directly from communities and about the details of what it takes for healthcare and social services and public health also to operate in greater alignment with one another. It's been really valuable insights from them about governance structures and roles and the roles needed. And their work is helping us, really better understand how to answer questions that we hear about how does this governance for sectors aligning work. The work that Allison, the 3rd speaker, talked about, so they describe attention as we consider what it takes for organizations to connect and align with one another. It's a tension between local design with local innovation and local circumstances, and then also developing a consistent replicable model. And this is a familiar tension to many of us. It influences how we think about spreading and scaling mechanisms to promote better aligned systems. Like, what are the most important elements, or actually maybe patterns, that we're trying to spread to more places? It just makes us think differently about this idea of spread and scale. There are insights, excuse me, about the importance of developing a shared purpose and governance structures for working together before shared data and measurement systems, and before a financing system with appropriate incentives and accountability. It gives us guidance about how we might design other funding programs to help communities. And we're sharing these insights and talking over the implications of them with existing programs that the Robert Wood Johnson Foundation works with that supports communities, like Data Across Sectors for Health. The JSI team's findings about trust and relationships, also they speak to that question I noted above about the interplay of technical and adaptive features. And the quote, "Equity is everywhere in theory, but largely absent in practice," it's really struck me. And it speaks to, well, that there's a lot more work to do in addressing equity in how systems align. So this year we've learned a lot about what it takes for public health, healthcare, and social services to work together in better alignment. And this team at the Georgia Health Policy Center team at Aligning Systems for Health has continued testing these theories about sustainably aligning systems throughout the COVID-19 pandemic and this period of widespread heightened attention to racial injustice. In the last slide, this year's really increased the urgency we feel around questions like those that you see on the slide before you. And we go ahead to the last slide. I just want to thank everyone. Thank you for your research, for those who presented. And actually, I see amongst the participants here that other people who are working on some of the other Aligning Systems for Health research projects are here also. Thank you for your research and for sharing your findings and progress. Thanks to all of you who are so interested in learning from and using this framework and these ideas and these insights. I look forward to opportunities to coordinate different things happening around the concepts in the framework. So if you wish, most of you are already connected to alignforhealth.org and following along with this work. But if you aren't yet, we welcome you to. So thanks so much for this opportunity to participate in today's conversation.
Thanks so much, Hillary. So we've been flooded with questions. So I invite the speakers to have a look at the questions in the chat, because maybe we can play a team defense and answer some of the questions in the chat, but not Muriel, because Muriel, I'm going to ask you the first question, the first spoken out loud question, because it's intriguing, the finding where sort of you said the clinical team had to get out of the way, and it seemed once they got out of the way, the quality of the referrals actually got better. Is that what we should take away from this? And if not, what is the takeaway?
So it's a complex takeaway. Once the clinical team was out of the way, the quality, that's not what changed the quality of referrals, because we lifted the eligibility criteria. So that's really what made a difference. But it increased the volume of referrals, and that means you don't need to have, when a clinician is running out of time or doesn't have time to have a certain conversations and so on, the one thing that we assume they will skip is the discussions around social determinants of health needs. So yes, that's going to increase the volume of referrals. And if the eligibility criteria are open, then more people get enrolled. But at the same time, it seems that in some cases, that one conversation that they have where they introduce the idea to the patient that maybe they can receive services and they vouch for these services seems to be playing a role for some patients in accepting services. So we initially, when we saw the results, we thought, that's it. Why did we ever ask the clinicians to get involved? It would be so much easier if we just reached out to everybody. But as we go along, it seems like maybe for some patients, yes, but some other, it really matters to have that introduction, and we want to find that sweet spot. And I saw that Dr. Lanford also asked the questions about the eligibility criteria. So I would say, yes, we thought that, oh, if we have a checklist, clinicians like checklists, it's going to be easy for them to implement, but that's not true. What really is needed in a fast-paced environment like in the health systems is to have very, very streamlined processes. And does that mean that the work of sorting out eligibility criteria fall on social services? Probably, but that means they're also able to identify other resources. If people are not eligible for their one resources, they can direct them to other resources. And that's where probably alignment takes place, is that everyone is confident within their role and not stepping into other people's space, but this is decided jointly.
Thank you so much, Muriel. Mark, it seemed like one of your main findings was that the Pathways Hub had a lot of alignment with the theory of change and the framework. This is kind of a two-part question. You mentioned governance, but what do you think you found missing from the Pathways model that that can be found in the theory of change or the framework, and vice versa? Are there things based on your experience with the Pathways model that should be considered for the latest iteration of the framework?
It's a great question. Thank you. So within the Pathways model and within governance, I think what we were seeing is that the hubs in their communities in some ways are being shy and not coming forward with county commissioners, local leadership, local representatives, political leadership, and some of the folks we surveyed were very adamant that the local hubs needed to do that, especially because they had specific data showing how difficult it is to identify, to address particular risks like housing, behavioral health, and others. And in the few hubs that are doing this well, they're seeing a lot of success. And then I think it's there in the theory of alignment, but one of the ways to summarize the hub model in a way very consistent with the other speakers, this relationship piece is absolutely critical. It's possible, at least to us, it seems like it's the most critical part. But the other component is defining what the work is that needs to be done and then getting it done. And it's in the data component of the core areas of alignment, and it's in the accountability part of the core areas of alignment. But defining the work and getting it done seems very important. And I would say that our nation has come up with clinical measures and has tried to develop pay for value, but we've done a poor job of it so far. It's not been universally successful, and it's an area of quality improvement and accountability that's really needed. Thank
you, Mark. Allison, you had several questions about equity, and we're just at about our time. If you can bang out a response quickly in the chat as I close us out, I think the audience will be thankful for that.
Great, will do.
I just wanted to draw everybody's attention to an opportunity we have. We are going to take a deeper dive on those 4 adaptive factors that have been identified in the new framework. I did see a comment in the chat about trust, and we'll be taking a deeper dive around trust in December. But this Friday, we're going to take a deeper dive around power and privilege with George A. and with the Greater Good Studio. He'll be doing a keynote that will be about 45 minutes from 1 o'clock Eastern time to 1:45. And with a separate registration, he'll be doing a workshop at 2 o'clock. It'll be a 90-minute workshop. if you want to explore power and privilege and what it means and how it matters as we think about designing systems, that'll be a great place to start. Hillary pointed out our website is alignforhealth.org, and you can find all the registration information for all of our events there. And Karen, I will turn it over to you for last words.
Thank you, Glenn, for organizing this, and thank you to the speakers. And of course, we appreciate the opportunity to partner with Hillary and others at the foundation. And I'm just really glad that we're able to participate in this learning system today. And I look forward to the next phases. Thank you very much and have a good afternoon.
Thank you all.